Great, thanks, Jerome. And as Jerome mentioned, welcome everyone. It's the Markey Cancer Center Affiliate Network's COVID-19 and Cancer web series. Most of our programming is developed and offered exclusively for McCann members, but due to the emergent nature of COVID-19, we've opened up the web series to those outside of the network. So if you're new to our McCann educational programming, we're really glad that you're here. Today's webcast is Cancer Care in Times of COVID-19, and I'm delighted to introduce our speaker, Dr. Reema Patel. Dr. Patel is an assistant professor of medicine in the Division of Medical Oncology. She's an associate program director of the Hematology and Medical Oncology Fellowship Program at UK. She specializes in the treatment of bone and soft tissue sarcomas, as well as colorectal, pancreatic, and hepatobiliary cancers, and provides systemic chemotherapy for sarcomas and GI malignancies. She's also part of the HIPEC program team at UK and designs treatment plans that delivers chemotherapy directly into the abdomen during surgery. She's passionate about medical education and provides training to nurse practitioners, medical students, and residents. I am not going to spend a lot of time talking. I'm going to turn it over to Dr. Patel, and to get us started, in this time of the COVID-19 pandemic, providers face new challenges when discussing treatment options and the implications of chemotherapy and triage and consent for patients with cancer. And we're wondering how COVID-19 has modified your way in approaching these issues.
So I think the first thing I want to do is I have a few slides, and I want to start with the slides because I think it'll give a general overall view of how it has modified what we're doing, not only what I'm doing, but what we're doing here at Markey, if that's okay.
Okay. Yes, indeed.
If I can get my slides to work. So actually, this is a very interesting, I don't know how many people have seen this, but this actually compares the death rate of COVID-19 compared to the top 15 other medical diagnoses causing death in the United States. So you can see that heart disease and cancer, the top two in the United States. And then if you look on the bottom right-hand corner, the date of 3/19 is listed there. I'm going to turn this little animation on, and you'll see actually how the rate of COVID-19 deaths rise over time in the next month. If I can get it, there it goes. So just watch the yellow bar at the bottom. As the days flip through, you notice that the COVID-19 case death rate is competing with and then outdoing heart disease and cancer in the United States. So as of 4/20, which was a couple of days ago, it was sitting nice and pretty at the top and pushing heart disease and cancers to the number 2 and 3 position. And I think that sort of helps illustrate what kind of situation we are in at this very different and interesting time in medical healthcare. There was a study that came out not too long ago in the Annals of Oncology looking at the cancer patient population in Wuhan. You can see that it looked at the patient population over a 6-week time period. It's quite a small study of only 28 patients, but they noticed that there was a male predominance, there was an older age predominance, and actually lung cancer was the most frequent diagnosis when these patients were coming in with COVID complications and cancer. And a lot of these patients were actually at higher risk of developing severe disease and worse outcomes if they had received chemotherapy in the last 14 days before admission, or if they were found to have patchy consolidation on their chest imaging when they had that done on admission. So this clearly goes to illustrate that the patients with cancer that develop COVID are at definitely higher risk of complications. The death rate in this study was at 5%. There was an Italian study that was published not too long ago as well that actually put cancer patients with COVID death rate at 7%, which is higher than the general population across the board. So some general tips, I have a few of these slides, but general tips for staff, and this is how we're managing things at Markey and how I have personally done my clinic. We're training staff to know the symptoms and screen patients and really employees for any of the possible symptoms of COVID. We're using masks for all providers and standardizing the use of PPE that's limited, such as the N95 mask, and how to also safely administer SARS-CoV-2 testing. So if a patient were to come into Markey Cancer Center with signs and symptoms that are concerning for COVID, we've actually designated certain rooms that are going to be our dirty or our COVID positive rooms. And patients are supposed to be sort of shuttled straight to those rooms, and all care is supposed to be administered there until we get the infectious disease folks and admissions involved so they can be admitted and taken care of in the hospital. So those are probably good general tips for the staff. Good general tips for the clinic. Really, we want to limit any access points into the clinic. So Markey actually has multiple access points, but we've limited to 2. And at each of those access points sits some of our techs that are screening patients for symptoms. We're asking everybody to sit or distance themselves 6 feet apart by using stickers and different signs in the building to denote what 6 feet apart looks like. And that includes employees and patients alike. We really want to decrease the waiting time in wait rooms as well. So we want to rapidly room patients. We want to do phlebotomy in patient rooms. Patients only, no visitors, which is incredibly hard for caregivers and family members. And if you have no option but to have patients in the waiting room, actually go ahead and space your chairs 6 feet apart, so you at least know that patients are abiding by the 6 feet rule. And then, like I said earlier, you want to designate COVID positive rooms in case you have a patient with a COVID screen that's positive. Tips for patient scheduling. Telehealth, and do it often and do it frequently. We know that there are patients right now that we have scheduled that are on our books that are probably in survivorship or probably in surveillance. You're probably not going to make the biggest difference in their overall outcomes if you were to move their scan surveillance back by 3 to 6 months. Now, obviously, this is supposed to be done on a patient-by-patient basis, and disease biology matters. But if you can safely move a patient surveillance and survivorship visit out, I would do so. The other thing is that, can you do telehealth for oral chemotherapy? So, patients that are on oral chemotherapy who have been doing well for a substantial period of time, let them get labs drawn either on a slow clinic day or via home health, and do a telehealth symptom check with them to make sure that they're tolerating things as well. Okay. And then patients should be instructed to reschedule if they develop symptoms. So when you have your schedulers calling, make sure that they're screening and patients aren't having any symptoms at that time, and patients need to be told to reschedule if they do develop any symptoms in the meantime. General tips for surgery. Now, this is me speaking on behalf of a surgeon. Please don't take what I say here as the golden rule by any means. Obviously, discuss this with your surgeon, but always discuss surgical management as a multidisciplinary team. A lot of the breast consortiums and thoracic surgery consortiums have come together with essentially priority A and priority B patients. And priority A essentially means that if you delay any kind of surgical intervention, it will be life-threatening to the patient. Versus priority B, delaying 6 to 12 weeks would not impact the overall outcome this patient would have. So I think it's important to start thinking about these patients as priority A or priority B. And then consider adding extra cycles of chemotherapy if needed to try to help them get past any COVID surges that may be happening or high peaks of COVID, or you don't want your cancer patients in the hospital. Try to keep them in the clinic as much as possible and then delay their surgery out. General tips for medical oncology. So I have some examples here, but really the goal is we want to de-intensify therapy as much as possible, but still be able to offer life-saving therapies, because that's what we're doing, is we're trying to improve people's quality of life and quantity of life in cancer care. So is it feasible to transition some IV chemotherapies to oral therapies? Can you start bridging with oral chemotherapy? So can you delay, again, chemotherapy or surgical interventions by giving them oral maintenance therapies? Can you go ahead and dose reduce for expected tolerability some patients that may be at higher risk for neutropenic fevers so that you can keep them out of the hospital. If you have multi-day regimens that are given 3 weeks in a row and 1 week off, can one of those days of chemotherapy be dropped? These are all questions that we as medical oncologists should be thinking about. Sometimes 4 cycles versus 6 cycles may be only of marginal benefit. So are you really going to get the biggest bang for your buck by giving 2 more cycles of chemotherapy? Maybe not, but you will potentially increase that patient's side effect profile and neutropenia risk, which could, land them in the hospital. So I think that we really need to consider spacing these kinds of things out if it's safe for the patient. Again, this is patient by patient. General tips for radiation medicine. Can radiation courses be shortened? So there's actually data in rectal cancer of doing a short radiation course. So that way patients are coming into the radiation medicine clinic less often versus doing the 6-week course, which is standard of care. Is doing stereotactic radiation therapy a possibility? So we actually discussed SBRT at another McCann talk I did, I guess 6-7 months ago now, but would radiation with stereotactic radiation be possibility? Because that's really only 3 to 5 sessions versus 5 to 6 weeks. So can we try to shorten the time that people are receiving radiation as well? Safely, of course. These were also some links that I'm sure Jerome can make available to you, but there are COVID cancer registries. We as oncologists, as radiation medicine doctors, as surgeons are really trying to keep our patients safe at home as much as possible, but also do the right thing for their disease process. And I think we need to learn how to balance that. But we also need to know that the interventions we make today did not have outcome impact later on in their care. So ASH and ASCO both have developed registries for patients. So if you have a cancer patient that is COVID-19 positive, that you've delayed care in some form or way, then they would actually like to know about these patients, de-identified, of course, so that they can actually put together a study or a database that we can all look at to make sure that these delays that we're doing based on COVID are not affecting patient outcomes. So I think overall, this will be a really good resource for us to have in the future to look back and see what happened with the changes that we made. And then just this week, I think New England Journal of Medicine did an article, a human interest piece on the untold toll, how pandemic is affecting patients that don't have COVID. So we also have to really play this balance of, people aren't going into the hospital right now because they're afraid of getting COVID, but other disease processes don't stop happening. Cancer does not stop happening. So we need to treat cancer with a steady drumbeat, and we want to make sure that we don't lose the human portion of what we're doing. So I think that we always need to balance our cancer care, our COVID care, and the humanity of what we do in medicine. So hopefully, Sherry, that answered your first question in a really big nutshell.
You covered practically all of the bases. That was perfect, just perfect. One thing that I think some folks are really interested in is the issue of telehealth, and we just had a broader telehealth discussion earlier in the week. Have you had experience with doing telehealth with your oncology patients or any of your colleagues? Can you talk to us about that a little bit?
Sure. So honestly, before all of this started, I had no telehealth experience, never did it as a resident, as a fellow, or, in my first couple of years in attending until, 2-3 weeks ago. Come to find out, I'm pretty good at telehealth considering that I'm a millennial. But, it's been really interesting. It's definitely interesting when you're used to human contact and having that humanity in medicine. It's very interesting to see how you can still maintain some aspect of that by doing telehealth. Definitely, it's not the same as a face-to-face visit, but I think that for a lot of patients, especially because a lot of our, cancer still overall is a disease of the elderly population, and it's a really good way for me to keep my patients safe that are coming into the clinic, as well as those older patients that can telehealth from home. We really want to keep them safe as much as possible. So it has been really nice. And I think a lot of patients have appreciated the fact that we are trying to do more telehealth during this time period. Like I said, we do try to get labs either outside or home health. so I can still monitor toxicity in the liver or the kidneys, electrolyte dysfunctions. But I think it is something that we are trying to do as much as we can. And thankfully, insurance is and Medicare and stuff are covering it. So that's a really good thing as well.
That's great. Another issue that has been come up, and in fact, we just had a webinar about an hour ago about virtual tumor boards. As part of the Markey affiliate network, we know that many of our hospitals have suspended their tumor boards, which is of concern when you are thinking about multidisciplinary care and making sure that, not only are colleagues talking with one another, but also making sure that patients are getting, the best high quality care possible. I know that Markey has kept with their tumor boards. And can you just talk for a couple of minutes about the importance of maintaining tumor boards, especially during this kind of a period?
Sherry, I would agree with you 100%. Actually, I think right now is the most important time to do tumor board. And the reason for that is if we were considering delaying patients' care, delaying surgical resection, or, making changes in their radiation treatment, I think that needs to happen as a consensus. So, for example, we have lung patients that have relatively small lung lesions at this time that are resectable. Any cardiothoracic surgeon would go in right now, cut it out, and we would be done with it. However, because a lot of places have had very limited surgery and OR time, again, to protect both patients and healthcare providers, we have made decisions to say, hey, this lesion is relatively small. Will it actually hurt the patient to delay a surgery by 2 or 3 months? And if the group agrees that no, in 2 or 3 months, understanding the biology of the disease, that it will not harm the patient, we are delaying it. But it is a group consensus. And then we have a very detailed conversation with the patient saying, hey, this was discussed in a multidisciplinary tumor board, or is it safe to give patients 2 or 3 more months of adjuvant chemotherapy so we can keep them out of the neoadjuvant chemotherapy before surgery, in order to keep them out of the hospital for a prolonged surgical stay, right? So I think all of these decisions need to be made as a multidisciplinary tumor board, because you have to weigh all the risk and benefits, and sort of bringing all your colleagues in together is the best idea.
Great. And I'll just do a real quick plug that last Friday, knowing that many of our McCann sites have dealt with layoffs and furloughs of many of their staff that have been involved in helping to set up and facilitate tumor boards and get data together and get the patient information together. We are offering support for any of our McCann sites that are interested in doing a virtual tumor board. So if anybody's interested out there, if you're a McCann member and your hospital is not currently doing tumor boards, get in touch with us, and we'd love to help in facilitating getting you started with a virtual tumor board.
Definitely. I would definitely take that offer up. And I see a question here in the group chat. Is it okay if I answer that, Sherry? So the question is, by reducing course of radiation, does that mean increase the amount of radiation received per treatment? No. So in terms of the rectal cancer that I quoted earlier, they actually looked at a slightly higher dose of radiation per fraction over a 3-week time period versus the 5 to 6 weeks, which is what we normally do. So not only was it a shorter time period with a slightly higher dose, but we were able to get all that therapy in with Xeloda as well, with the corresponding oral chemotherapy that we normally give. So you can not only increase the dose, but you can also decrease the time if needed. And then again, SBRT if possible. So that's only 3 to 5 sessions. I hope that answered the question. And then the next question was, has there been an increase in patient anxiety, fear, in canceling their treatments or not showing up? And it actually looks like my nurse answered that question, which is great. Yes, we have had a lot of anxiety, and patients have had to or wanted to push back, delay, things like that. The patients that I've encouraged to keep their appointments are the ones that are on active chemotherapy. We're trying to make as many adjustments as possible, but again, we have to balance, treating their disease with also, keeping them safe and prevent COVID infections from spreading. We don't want to forget their cancer care because we're so afraid of COVID.
Reema, one of the other things I was wondering about is, in addition to treatment and how concerned people are about continuing their treatment or, holding off on that, I know that so many of our supportive services have some have been suspended at hospitals, some are being provided in different ways, like nutritional therapy and physical therapy. Can you talk a little bit about how those services are continuing at Markey and UK?
Yeah, sure. So I know that a lot of our nutritional services, social work have gone to doing more phone call visits. They've also, I think, also done some Zoom conferences. So what they do is of the group, maybe one or two of them is physically on site in case something needs to happen more immediately for a patient. But if a patient can be triaged and say, this nutritional question can be done via the phone call, then they're trying to do things more via phone or Zoom. I think things such as doing mental health activities, because that's also part of the care we provide in the integrative medicine department. So mental health and things like that, I know that a lot of the live demonstrations and smoothies and all this stuff that we do for integrative medicine can't happen on location. But I think, there are a lot of programs and institutions that are doing Zoom Tai Chi and Zoom yoga and Zoom meditative programs together. And I think that's a really great way to still have people feel the community and the support, and they don't necessarily need to be there. And honestly, I think that we're being forced into using telehealth and stuff right now because of COVID, and it hasn't really seen this rise before. But I think things like integrative medicine and such will be really ripe to offer these ancillary services to patients in a more virtual format, even in the future. I think that sometimes when we make steps forward into these things, it's hard to take them back. So I think that now that telehealth is here, it's not really going to go. And so I think ancillary services should also envelope themselves in telehealth and try to provide these services via some kind of interactive virtual format. And I think that's also a really good way of reaching patients that in the past have said, oh, I don't have time to go to that yoga class, or I don't have time to go to that journaling session that the cancer center provides me. If we could do it virtually and patients can do it at home, I think that may take away some of the excuses that patients have for their mental health as well. And we as health providers are also bad at that, using excuses not to, make sure our mental health is intact. So I definitely would encourage our care providers to also do those virtual things if they're offered. I think Headspace, for instance, is giving free meditative sessions to all healthcare providers right now. So I don't get any commission from Headspace, by the way. I just threw that out there because I know it exists.
Hey, Reema and everyone else, if you're an affiliate member right now on our resource portal, we have a weekly meditation podcast that's presented by Dr. Connie Jennings. And also we have, I think, 4 integrative medicine videos that are currently out there on the resource portal.
Brilliant.
Yeah. I have a couple more questions that were sent to me.
Okay.
So here we go. Here's a long question. Bear with me. I need bifocals. Our facility allows no visitors with patients during the pandemic. New cancer diagnosis patients are in need of additional support with extra ears to capture all the information. We have helped connect patients, family members on FaceTime during the visit and utilize navigators to assist the visit. Any other suggestions that you have found helpful, or that anything that Markey is doing that they haven't mentioned?
Sure. So I 100% agree with the FaceTime. I've done telephone calls. I've done FaceTime. I've actually seen some of our surgeons go outside of clinic, go find the wife in the car and talk to the wife. Sometimes it really is that face-to-face contact that makes the biggest difference in the world. Based on the patient, I have asked our clinic folks to make exceptions every now and again. So if we have a very elderly patient that really just does truly need someone there with them, I have some relatively young patients that are considered minors that need at least 1 or 2 parents there. So we allow one parent back. So I think those exceptions obviously are there. You know, other things that have been unique that we've done is that a lot of our surgical colleagues, when they have quite a few patients in the hospital, their nurses from the clinic are actually rounding with the inpatient team as well, so that, you know, this nurse obviously has a connection with the patient and the family member from the outpatient setting. Now this patient has surgery, but the visitor can't come in. The nurses are actually rounding with the team. They get an update for every patient. And then they're making phone calls once or twice a day. So they're actually, you know, so someone who has known the patient through the entire spectrum of the inpatient and outpatient setting is making contact with them. So that's one way that we've utilized this. We also, you know, had multiple people. I know some people have had, you know, multiple family members on Zoom. So the patient will come in and then they'll do a Zoom link for the rest of the family members. So that's possible as well. I think it's a very challenging time. I don't know that I have any other great ideas. I think it's just really important for us to continue to keep touching base as much as we can and encourage them to ask questions, because we want to make sure all their questions are always answered and their fears are put to rest.
Should immune compromised patients be taking antiviral medication as protection?
That is a great question. Actually, ASCO and ASH do not recommend that at this time. So we have patients that have leukemia that are on antiviral therapies. That is standard of care. That has not changed. And you should still continue that. However, you know, a patient that is receiving FOLFIRINOX for pancreatic cancer who has a higher risk of becoming neutropenic, no, we would not put them on any antivirals or any antiretrovirals prophylactically at this time. That data is not there. And obviously we would run the risk of making, you know, side effects and interactions and drug interactions happen. So that would be something that we would have to monitor very closely. So, but it's not a recommendation at this time.
Should people still be going in for cancer screening at this time?
That's a great question. So I think that most of our cancers that we screen for at this time, colon cancer, cervical cancer, lung screening, most of those cancers, assuming that it's not a small cell lung cancer, tend to be, I shouldn't say indolent because cancer is not really indolent, but they tend to have a more predictable rate of growth. And if we know that colon cancer screening can be delayed by 6 months or a year and not have a great detriment to patient, I think I would safely do that. Same thing for lung cancer screening. I would push it back for a couple of months. You know, low dose CT is really easy and fast to schedule and get usually. So pushing it back a couple of months, I don't think is that big of a deal. As it goes for cervical cancer screening. Mammograms as well, I would take the same approach. You know, if a patient has not had any lumps or bumps that you're concerned about in the past, or things that you are watching, then I think it's reasonable to push it back by a month or two, if feasible. But if there's lesions that you have been watching that are of concern, then I would stay on top of it, because ideally we do want to catch things early on, because the earlier we catch things, the sooner we can implement therapy, and it tends to be more curative at that stage. So I think it's a balancing act, really.
Are there any special precautions cancer patients should be taking?
Any different recommendations than before in terms of like their normal health stuff? Is that what you mean? I guess. Yeah. So I mean, I think we all are supposed to be taking the same precautions. You know, the CDC is recommending cloth masks for everybody, plenty of hand sanitizing, cleaning, lysoling surfaces and things like that. That's your general sort of care. In regards to medical care, the CDC, ASH, ASCO, they're all sort of together in saying that we don't need to make any other different changes at this time. Again, like I said in my little PowerPoint, you know, if there's ways for you to decrease the risk of patients having low white counts, I would take those as possible. One thing that ASCO did come out with is that normally we would not recommend growth factors unless we know patients have neutropenic fever risk of greater than 20%. ASCO has recommended considering growth factors in patients if the neutropenic fever risk is 10%, so it's lowered the risk. Now that may be a concern with insurance, starting growth factors ahead of time, but that may be something that we as physicians and care providers need to make peer-to-peer phone calls for and things like that. So that would be the one big thing that I saw as a change for patients with cancer, is lowering the threshold for growth factors. Then that's by ASCO. That's not a NCCN recommendation or anything at this time. While Jerome's looking, there's another question that popped up on mine. Regarding the virus itself, do you think we are seeing the worst yet? Not regarding the curve, but rather, are you worried about a potential second wave that some are saying can and will be worse? To be honest with you, I feel like right now where we stand, we probably have hit the majority of our peak. I am concerned here in the state of Kentucky, though. We did have some places that broke the social distancing rules over Easter weekend. If we were to see a surge or a spike related to that, that's going to happen around this weekend, because that would be the 2-week mark. So I think that would be telling if we see a little spike again in the next week or two, because that would be from the Easter weekend activities. But I think for the majority of it, I think that we in Kentucky at least can say that we have plenty of resources to sort of get through the current status that we're in. Am I worried about a second wave? I am. I think that this virus, if we think about the flu, it's a virus that's pretty virulent, has a tendency to change, which is why we never get the vaccines right every year, right? This virus is actually more virulent, more contagious than the normal flu is. And my concern is that it will sort of morph, change, mutate over time, and that we may see a second wave that potentially coincides with the next flu wave in the fall winter area that could be more detrimental. I think right now all the science is concerning that could happen as well. So I think that the implementations and practices that we use now, even if we relax them during the summer and early fall months, we may have to re-implement some of those things in the fall and winter again coming up.
Does having received chemotherapy or radiation in the past raise your risk of getting COVID-19 or having a more serious illness?
That's a great question. So we know that, sort of as I mentioned before, we know that patients that have cancer, they do have somewhat worse outcomes than the general population. I think that goes along with the fact that many of these patients have other comorbidities. We will have just given them chemotherapy or some other intervention that would make them immune compromised. So I think the simple answer is yes, they are having worse outcomes and worse prognosis, but it may not be necessarily because of true cancer complications. It's probably cancer treatment complications and COVID on top of that, if that makes sense. So I think that the general rules, the things that I've always actually said this to my patients, that when you have cancer, you're receiving cancer treatment, you have to pretend like you are the only healthy person and everybody else has the flu. I think now instead of flu, I'm going to start saying COVID. But you have to pretend like you're the only healthy person. So, you have to put the nidus on yourself to make sure you're protecting yourself, your home is staying clean. All surfaces that are frequently used should be Lysoled and cleaned frequently. Those are really the best and smartest sort of interventions that you can make at home. I have family members come to me all the time and say, hey, should this person be tested because my husband has cancer and he's getting treatment? No, I mean, they don't necessarily all need to be tested. Right now, we don't have the testing capacity yet in the United States. Everybody's ramping up. And it would be great to know who's negative and who's positive, but we don't have that ability right now. So I think that patients and family members taking it upon themselves to be as safe as possible is a good idea. And really anyone that potentially could be sick, if people have been out in public and you're not sure, whether they were wearing a mask, whether they were protected or not, just don't let them come home at that time. Make them self-quarantine. It's a very hard decision. You want to be able to see your family and friends, but I think that you always have to sort of be very careful in this.
We've all heard of hydroxychloroquine.
Yes.
Is that something that a physician should be recommending for patients with COVID-19?
The short answer is no. Hydroxychloroquine, when it first was touted, people may have overdosed on it and led to severe complications in GI and cardiac health. There was a study that recently came out, I think from Africa, looking at patient population that was treated with hydroxychloroquine, and they actually had an increased incidence of cardiac events. So if they're not having complications from COVID, they were having complications from heart things because of the treatment we were giving them. So I think it needs to be very carefully done. There is no clinical trials right now that say that using hydroxychloroquine is the answer. Remdesivir, which is an antiretroviral therapy, previously looked at in HIV and AIDS. It also was looked at during the MERS pandemic, I think, or no, epidemic. MERS wasn't a pandemic. I think it was looked at during MERS as well, and maybe Ebola. And that seems to have some promising data, but we still don't have any randomized clinical trials. There is, I think, more hope in the remdesivir, though, than in hydroxychloroquine. So I would not be surprised if more and more institutions are trying to get remdesivir on compassionate use basis right now. So it's not technically approved, but I think you can get it as a compassionate use basis.
Are there any long-term effects of having COVID-19?
Oh man, that's a really interesting question. I think that right now it's still too early in the data to know, but I think there is some concern that there's prolonged T-cell immunosuppression that's happening. So it's almost acting like an HIV type of virus, even though it's not in the same family. It's having a very interesting side effect on the immune system. The data is really early on that though, so I don't know if it will pan out or not. And I think that other patients are having non-pulmonary complications that we weren't expecting, like having higher risk of cardiac events and things like that. So I think that once a lot of the dust settles, that will all really pan out. But I think cardiac and immunosuppressive sort of long-term things are the consideration right now, and things that we will need to watch for in our patients as they're recovering from COVID.
Here's a question I always get. Will this be recorded, and where can I watch it?
Well, I know that it's going to be, let's see, this is one of our, the programs that will be available for a short amount of time on our resource portal. Is that correct, Jerome? Yeah. And one of the things that we are being very cautious about is keeping material up because the information is changing so rapidly. So this will be available on our resource portal. You have to be a member of McCann to get that. And if you are a member of McCann, but you do not have access to the web portal, you can send an email to Jerome, JERONE.Farley, FARLEY, at UKY.edu. And then for those that are non-McCann members, I believe that we have a site that they can go to access, Jerome?
That's correct, Sherry. We now have a public-facing YouTube page. So if you just type in Markey Cancer Center COVID-19, it should take you to that YouTube page. If you have any questions, you can shoot me an email at jerome.farley at uky.edu.
And I will throw in there that a lot of the information that are in my slides, I did pull from ASCO and ASH. Their websites actually have tons of information. I can make the web links available to Jerome if he wants to put them out there as well. I tried my best to consolidate them into really big key points. But if you really want to get into the nitty gritty, all sort of the recommendations broken down by disease process and stuff is available on ASCO and ASH as well. It gets really nitty gritty though. So be careful. You can get into the weeds and the rabbit hole if you look at those websites too.
I would like to thank, first of all, Dr. Reema Patel for a very informative presentation in such a uncertain time. Also, let me thank Sherry Toll for being our moderator today. And thank everyone for attending. Be safe, everyone, and take care.
Yeah, stay safe, stay COVID free.